Welcome back to part 2 of our rapid review of ECGs. So if you're here, you've already seen part 1, signed up for a free account on Picmonic.com, and learned the 5 Picmonics from the playlist. Now let's continue on to part 2 in this series of ECGs. Take it away, Dr. Wyatt.
Now there's a couple of other important ones, and you really got to know these. I've just got the most important ones here. I talked about that prolonged QT already, but what about a U wave? Where do we see a U wave? I didn't even mention the letter U yet. It's like I'm, oh goodness, what is that guy? He's like, let's talk about the letter U. What's the U? Well, the U wave is PQRST and then U. Essentially, it's another wave out here after the T wave. It's another one. There's another little wave. It's not another P wave, and I don't want you to concern it for that because it's really difficult to be able to identify a U wave. Most commonly, you're going to be told about a U wave, and then you need to know that it involves potassium. And exactly in the opposite, this tall peaked, it involves a low potassium, so hypokalemia. And I just remember that a U wave is shaped like a U, so it's a decreasing potassium. Now, when we talk about the T wave, this tall peaked T wave, this one you're going to see very often as well. And here's a great example. So I got my P is right here, kind of hard to see, QRS. And I got this giant T wave. I mean, it almost looks like a QRS complex. It's bigger than. But it's after the QRS, and it's a giant T wave. It's a tall peaked T wave. Number one sign of hyperkalemia in the tall peaked T wave. And that's really important to make sure that you know. A tall peaked T wave. So just make sure that you know that stuff. Those are two ones that they're so commonly tested, but also if you have a patient who's just fidgeting, or twitching out of control and they're having problems and they're a renal patient, then you find out that, the tall peaked T wave, well, that's because, you're going to see that on the ECG and you're like, wow, that person may have hyperkalemia. Look how tall, look at that T wave. That's crazy. And of course, then you can treat that. But remember that potassium is very, 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 cardiac, it's very, it affects the cardiac system a lot. It affects the heart, and imbalances are, the heart's very sensitive to those imbalances. That's why we can see it on the ECG, and of course it causes arrhythmias very easy. So here's just our potassium Picmonics. You can go check that out if you want. So I'm just going to kind of skip. I kind of already talked about each one of these, but I want to talk about the ST segment. So as we look at the ST segment, this segment right in here, this between the ST, we know that the ST segment essentially can be what? What is the ST segment? Well, the ST segment, if you're thinking about cardiac injury. Yes, that's absolutely right. So you're thinking about cardiac injury. The answer is yes. It's not. It can be cardiac ischemia and then cardiac infarction. So ischemia just means oxygen starvation. So it just means that it's oxygen deprived. Whereas ischemia actually means cell death. So if we have cardiac ischemia, we may see a depressed ST segment. But if we have cardiac ischemia, a true infarction, that's where we see that ST segment elevation, and that's absolutely right. So that's where you'll see that, and that's just really important to make sure that you know those. Here's our little ST segment deviations. These are important to knowing in infarction. Here's some examples. So here we've got under the B here. Here we see this P, QRS, but the S doesn't ever go back to the isometric line. Well, that's because we got our S. The S is almost gone, but it's there. I mean, you got to understand it's going to be where it comes down and starts deviating back to the new isometric line, what it thinks is. And then we got coming over to the T and then back all the way down. Opposite of that, over here under our C example, we've got our P, QRS, and then it comes way down below the isometric line before coming back above to the T wave. So somebody asks about, will the T wave be obvious, Stephanie? And how big is the T wave going to be in hyperkalemia and the changes? It really just depends on the severity of the potassium imbalance. It could be huge. It could be like the example that you see there, but you're probably going to see other types of symptoms. It may not be obvious, but what it may not be is it may not be a beautiful rounded. It may look like a teepee. It may not be very big, but it looks like a teepee, and that's because it's literally rapidly depolarizing straight up and straight down. It may look very pointed, and that's why we call it tall and peaked T waves. And there are algorithms being able to check the T wave to the QRS complex. That's the physiology stuff. I'm not going into that for what we're going to talk about now. Now, when we look at a myocardial infarction, the ST elevation that you see could be very different. And I don't want you to focus on trying to always identify ST elevation. I see so many people learning ECG in the beginning, and they're just so focused on trying to find ST elevation that they're not focused on making sure that they're just good at reading ECGs. So there's just some examples. So they can always look differently. Look how this one looks different from this one. This one looks different from this one. These are all ST segment elevation. So there's no P wave in any of these. That's on purpose. But QRST, QRST. Then we got a QRST. And then we got a QRST. So it's going to look different, and it's based on the evolution of the myocardial infarction itself. So all of that, lots of basics, lots of things to understand. I get it. If you don't understand all of the basic stuff, I recommend making sure you really know that. But number one, you've really got to know how you can calculate a good rate. That's what's super important. You got to be able to calculate a rate, and you got to be able to know how to get the rate correct and make sure that that is indeed working. And that's definitely one of the things that you just have to know. So we're going to go through some rhythms. But first thing, when you learn anything, I think when you're learning any type of new skill, and I'm not somebody who usually harps on so many basic things, but you've got to learn a process. It's just like baking a cake, doing ECGs. It's like doing anything. You've got to follow a very certain pattern. Otherwise, you're guaranteed to make mistakes, because then you're going to just keep ending up with, what do I do now? This one looks weird. Ooh. That's not what you really, that's what's going to happen to you if you don't follow the pattern. And we got a pattern here for you. If you've learned ECGs in a little bit different order, that's probably okay. So you don't have to follow my order exactly, but it is a set order that it does equal success every single time. And then there's the weird crap at the end where there's a few anomalies that you just have to know. And we'll talk about some of those as we go through. So as we go through, this is what everything we're going to run through today. We're going to go through, if anything, making sure you're a master of the process, because that's what's going to make you be able to understand what's going on and just not make any of the, what I want to call basic mistakes, right? The things where you're like, oh my God, I can't believe I missed that. Because that's where so many people with ECGs, they miss those. They miss the basic stuff. And if you're saying it's not you're not that person, I'm telling you, I worked as a paramedic for a long time, and that's one of the big paramedic skills is doing ECGs. Oh, I was so bad. I didn't realize how bad I was until I relearned it and always follow the same process now. And I think that's really, use my learning example. Don't do what I do. So we're going to talk about, first we're going to go through looking at the rate, and we're going to run through this, each one. We're going to look at the rate, and we're going to determine the rate. That's the most important thing, because then is the heart going too fast or is it going too slow? We're going to look at the rhythm of what's going on. We're going to see if it's doing the same thing, if it's regular, or if it's irregular. Then if it's irregular, we're going to break that down, and we're going to say, is it doing the same thing every time, or is it doing a bunch of weird crap? After that, we're going to look at the P waves, and we're going to say 3 questions. We're going to say, is there one before every single QRS? Are they upright? Are they consistent? Upright, rounded, and consistent. Then we're going to look at that PR interval, making sure that it's less than 0.2 seconds for what? Heart block, yes. And then we're going to look at the QRS complex itself. We're going to look at the QRS complex, and basically the last one is like, is it wide or is it short, right? Is it greater than 0? I like to say 3 boxes, just for simplicity's sake. And you see some variation in the text on 0.1 seconds. Woo! There's a little Freudian flip for you. And then 0.12 seconds. But you're going to see that, and then I always just in my mind think 3 boxes, because I know 3 tiny boxes are 0.04 seconds apiece, times 3, 0.12. Mainly because I'm a math nerd. Now we're going to look through this, and we're going to run through these examples, and we're actually going to run through this together. So if you didn't catch all this, don't freak out. I didn't intend to harp on this giant list, because we're literally going to run through this, every single one, and as we start with the basics, a basic regular rhythm, we're going to build each one, and we're going to go through it, and we're going to see how we're building through the process. Because if you can get the easy ones, then you can move to the harder ones, and the harder ones, and the harder ones. Yep, you'll get it. So let's talk about a sinus rhythm, okay? I'm not going to read all of this crap to you, because I think it's a waste of time. You can watch this later. You can scribble it down. I think I've got the DVR turned on YouTube, so you can actually pause it and stop me And it's still going to be playing on YouTube, and you can stop me and make some notes, and then you can push play again. It's all there. I'm pretty sure I turned on the DVR thing. It's one of the great things I love on there. But what's really important is a sinus rhythm. Well, what does a sinus rhythm mean? Well, a sinus rhythm means it originated, hopefully, from the sinoatrial node and traveled down through the right path to the AV node and then out. Sinoatrial node. So that means it originated from the sinoatrial node, sinus rhythm. That's where that comes from. Sinus doesn't mean your nose sinus. It means normal, regular, expected, all those whatever synonyms. Now, when we look at this, here's the same pattern. You're going to notice this exact same thing: rate, rhythm, P waves, PR interval, QRS. It's going to look the same way on every single one of these we look at. You don't have to go into the details on each one. And when I talk about the leads and all this stuff, don't even worry about that stuff when you're starting out. I mean, I think you need to know lead placement, and that's a separate talk. I had to cut it out of this because it's just too much stuff. But one of the things, so you got the rate, rhythm, P waves, PR interval, QRS. In a sinus rhythm, let's look at the rate first. What is the rate? Let's say this is a 6-second rhythm. What's the rate here? Someone tell me the rate. So somebody count. I can't count today. I should make like a cheat sheet for myself. 1, 2, 3, 4, 5, 6, 7, 8. So it's about 8. Actually, this is the same rhythm I just showed you a minute ago. So that I just realized that. So the rate is about 80, right? Now, when I say the rate, when I talk about fast and slow, what's a normal heart rate? You got to know that one. 60 to 100 beats in an adult. 60 to 100. Is it faster than 100 or lower than 60? No, it's normal. That means it's a normal rate. Rate, regular. Now, rhythm. Now, here's where it gets a little tricky. Rhythm, you've got to be able to say, is this doing the same thing over and over and over and over and over and over and over? Yes or no? Now, how do we do that? Now, first time I'm going to explain it to you with the perfect one, and then when we get into the harder ones, we're going to have to do some finger motion. I like to use my thumb. So when we look at the rhythm, the way you tell if the rhythm is regular, what you actually have to do is you have to check you have to look at the R to R interval. So here's the R, there's an R, there's an R, there's an R, there's an R. You get the point, right? And then you have to say, are they regular? Now, I like to use the thumb method here. This is my beautiful thumb. I have the most beautiful thumbs that anybody has ever had in the world. These are the best thumbs, and I know thumbs, okay? So I like to just literally every time, whether it's on an ECG monitor, whether it's on anything, I literally just thumb it. And I take my thumb, and I literally just put my thumb right up there, and I angle it to where it's about right, and I just eyeball it, and I'm like, yep. It's almost the same distance all the way across. There's no wide variations. Thanks, DuckButt3385. Great name, by the way. Thanks for the thumb compliment. For you guys on GoToWebinar, DuckButt3385 just gave me a compliment about my thumb. So what you need to do is see if it's regular. Is it the same distance? What you're looking for is you want to see if one's scrunched together or one's farther apart. That would be maybe not irregular, and we're going to talk about that. But you don't just have to look at the R to R's. To truly say that it's regular, you have to look at the P to P's too. So you got to look at the P to P's. So you're going to be able to identify. So there's the P, so P, Q, R, S, T, right? So there's my P, and there's my other P, 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 P. And I'm doing this one slowly on purpose because you're going to have to be able to do this, and it gets harder. Of course it gets harder. That's the whole point. That's why this is a difficult subject. But what the important thing here is that you've got to be able to understand the basics. So this is the normal rhythm. I'm telling you it's normal. And when we look at harder ones, then you're going to have to be able to figure it out. Somebody asked, is there a handout? You can always check this out on YouTube. I do have a PDF of some sample rhythms for you to try, and I'll post it in the link of the video afterwards, or I'll send it out in the email. It's just a rough set of rhythms, and you can just try them on your own, and then it has the answers. But as far as a handout, you just kind of have to watch the YouTube. But getting back to our regular, look at our P. So I take my beautiful thumb again, the best thumb in the world. I mean, I know thumbs. There's no thumb better than this one. Magical thumbs. Then I take it and I put it down there, and I'm looking at the distance again. So I'm looking at the distance, and of course, when I look all the way across, they're very close. Now, when I say close, I mean if it's one box away, 2 boxes away, perfectly normal. We're not trying to micro scrutinize this. This is a rough. thing. And it's, it's supposed to be, because what is one thing that will create a variation in a heart rate in a normal, healthy individual? And you got to know about this for real life. On the test, they're not going to give it to you. But actually, I think I have a slide on this, so maybe I shouldn't talk about it. But one of the things that changes your heart rate is breathing. If I take a big, deep breath, what happens if I hold that big, deep breath in, or I took a big, big, deep breath? I've increased the pressure in my heart, or in my intrathoracic cavity. I've caused increased pressure. My heart then can't fill as easily, so my heart rate needs to speed up a little bit. And that's called a sinus arrhythmia. It's a little beat that's just going to be a little bit off place. That's perfectly normal. If you're seeing it slowly speed up, just a little bit over a couple of beats, perfectly normal. I think I have an example here to look at it. Now, looking at the rest of it is super easy. For this, I look at the P waves and I say, are they upright, normal? Is there one before every single QRS? Yes, 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 yes. Yes, there is. Then I look at the PR interval all the way across. Beautiful. I mean, there's no way I've got 5 boxes in between there. Not a chance. Then I look at the QRS. There's not a chance, literally just even glancing at it. Is there more than 3 boxes in between that QRS? Not a chance. I don't even need to look at all of them and tell you all the way across. Absolutely not. So when you kind of condition yourself, you quickly get the basics. And we're still basic stuff. Then when we start doing these faster, we're going to go faster and faster and faster and faster and faster, right? That's the idea. So let's look at this one. Tell me what the rate is. This is a 6-second strip. You have just a few seconds. What's the rate? The rate is about 50, right? The rate is approximately 50. Approximately. Now, 50, is that between 60 to 100? No. Is it fast or slow? It's slow. It's a slow rate. It's approximately 50. It's a bradycardic rhythm. Now, is the rhythm regular? Ooh, I gotta have a little bit bigger thumbs for this one. Look all the way, my R to R's, yes. I look at my P to P's. P to P to P, 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 all the way across. Beautiful. Very consistent. Is there one P wave? P, QRST, PQRST, 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 PQRST. Yes, beautiful. So if I look at that, and then I look at this rhythm, when I look at the P wave, how do I know that this is a sinus rhythm? I forgot to mention this on the last one. I know that this is a sinus rhythm because there's a P wave there. It's there before every QRS. That means it's and it's positive. It's upright. It's upright, and it's one before every QRS. That P wave right there, that little nugget, that P wave tells me that that originated from the sinoatrial node, meaning it's a sinus bradycardia. So it's originating from the sinoatrial node. There's one before every QRS. That means it probably caused it, right? Yes. And that means then that that's a sinus bradycardia. So that means it originated from the sinoatrial node. Come here, Stitch. Sorry, my Stitcher's here is about to have a moment, I think. I don't want him to bark. So so that's how I know that that's a sinus bradycardia. So, Jack, for you, just important to make sure you know, and maybe you're answering something because there is a little bit of a delay, but what's important to think about when you say bradycardia, make sure you're always saying sinus bradycardia. Because if it's not sinus bradycardia, then you know that it may be, that's where we get into something called junctional rhythms. Junctional because of the AV junction. That means it didn't originate from the SA node. If there's no P wave, that means it's junctional. That's just a side note. We'll talk about that here in a second. So let's look at this one. Someone tell me the rate. 13, right? 13, 130. The rate's about 130. Beautiful. Now let's look at the rhythm. You got to have really tiny thumbs for this one. And I don't have tiny thumbs. I have big, beautiful thumbs. But if you have tiny thumbs, wow, I couldn't imagine if you're on a mobile device and you're really trying to use your thumbs. But if you look there, it's regular. The R to R all the way across is beautiful. The P to P. Now I know it's hard to see those P waves, but they're there. Look, they're right there. P, P. And as the rhythms get faster, it's harder to see the P waves. Yes, it's absolutely right. It's like having a toddler. Just stitches. You're just like a toddler. So that's absolutely right, and it's regular. And the R to R, also regular. So R, 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 all the way across. Now there's a P wave. Is there one before every QRS? Yes. Is it upright? Yes. That means this is a fast rate, right? Because 130 is above 100. That's right. We did math. And it means it's a tachycardic rhythm. So you say tachycardia first. Then when you look at and you say regular, yes. Then we say P waves. There's one before every Q or S. That means it's sinus tachycardia. So then we've added tachycardia. Now we say it's sinus tachycardia. And that's how we know exactly what it is. PR interval, of course, on a fast rate, it's really hard to see a true heart block. So we're going to look here. There's no way there's any of those are greater than 0.2 seconds. So from here to here, no. There's literally one or two boxes in between there, right? And that's how we know it's sinus tachycardia. QRS, just glancing at those, you know there's no chance that there's 3 boxes in between there, right? No, there's not. That means it's QRS is perfectly fine. So not a problem at all. So this is a sinus tachycardia all the way across. Beautiful.
That completes part 2 of our rapid review of ECGs. In this part, we learned about hypokalemia, hyperkalemia, sinus bradycardia, and sinus tachycardia. To watch the finale of this 3-part series, just click the link below. Picmonic subscription is required. Along with unlimited access to these full webinars, as a Picmonic Premium member, you'll be able to watch over 1,000 Picmonics and really master the content. And then you can quiz yourself on what we covered in this series. In part 3, we'll be learning about deciphering the different heart arrhythmias and the little details you need to know.
Basically, lots of different rhythms that are too fast.
See you over at part 3.